We are very pleased to have Imelda here today, talking about clean energy access, gender disparity, health, and labor supply. Imelda just recently started at the Graduate Institute in Geneva, and yeah, it's a pleasure to have you here with us. And we proceed as normally. We have 45 minutes of presentation, and please save your questions then until the end. So we have questions and discussion at the end. And this time we will enable cameras for everybody then at the end, so that when you make a question, please also turn on your camera so we see who's talking. And if in between, if you need a clarification on something, you can ask a clarifying question in the questions and answers panel, and I'll try to let Imelda know about that. Okay, good. So please, the floor is yours, Imelda.
Okay, thank you very much for having me. I'm Imelda, now at Graduate Institute. I do some work on electricity, renewables, but today I'll be speaking about energy access in developing countries. And this work is joint work with Anjali, a PhD student at Texas Austin, will be on the market this year. So first, let's discuss briefly about how energy, health, and gender are linked. So a key source of inequality stems from the way men and women are expected to spend their time. Because of the traditional gender roles, women spend a considerably higher amount of time on unpaid housework and care than men. So they have less time to contribute to market work. So some evidence has been documented, for instance, show that motherhood affects influence women's careers, female labor participations. And so turns to the energy, how access to energy can help fill some of this gender gap in labor outcomes. First, access to energy allow us to use modern appliances. So it lowers the time burden of doing household chores. So one study shown that the invention of modern appliances such as washing machines, vacuum cleaner, explain the increase of female labor participations in the US over the last century by freeing up women's times away from housework. And there's another channel, another possible channel, which is reducing health burden. So access to energy allow us to use cleaner technology, there's less polluting, so hence household members can enjoy improved indoor air quality at home. So as a result, women and children may be sick less often. Women can now have more time available. So, and it opens up women opportunity to participate in market works if they want to. So really the research questions we're after here is how does having access to clean energy improve health? And since health is an important determinant for labor decisions, we also want to know whether it can influence a labor outcome, the access to clean energy. So to answer these questions, we are focusing on cooking technology, mainly because the gender aspect is dominant for cooking activities as shown in the pictures. As we know, cooking exclusively links to women, especially in developing countries, and this leads to disproportionate health and time burden on women if they use unclean cooking technology. And not only that, cooking technology is also of interest in terms of policy perspective. So mainly because it's a large scale issue. As per today, roughly 40% of the populations do not have access to clean cooking. And it has a large adverse health effects. It's already been documented by WHO, claiming that these household or indoor air pollutions mainly comes from unclean cooking is associated with millions of deaths annually. And since the impact is so large, there are broad interest from other countries on policies that can successfully influence the adoptions to cleaner cooking technology. So this is some effort of many countries, they implemented policies, increased percentage of their populations with access to clean cooking. However, over the last 18 years, generally it has moved slowly, gradually. Most common government interventions is providing subsidy to cleaner cooking alternatives. And lessons learned is that it's not that easy to encourage people to switch to clean technology. Providing access to clean cooking may not be enough because people may still have low willingness to pay for clean energy. They're probably myopic. They often do not internalize the benefit of clean cooking. And it is also true that in some cases, when subsidy is removed, households tend to go back to their old alternatives. There's some evidence, for instance, in RCT, randomized control trial, trying to understand why adoptions on clean cooking is so low. It can be due to low bargaining power of women. In some cases, giving clean stoves for free, people take it for granted. Many did not know how to use it properly, using it for a while, it's broken down and they stop using it. So in general, it's been hard to study any impacts of clean cooking because so far we've been struggling on how to increase adoption. So Indonesia provide a suitable laboratory to answer these questions because due to their successful clean cooking interventions. So in the last 10 years, Indonesia went from being one of the countries with the lowest shares of populations with clean cooking to having one of the highest shares with clean cooking compared to other developing countries. And the reasons behind this remarkable progress is that the government not only subsidizing cleaner alternatives, but they also restrict the supply on the dirty alternatives. So they're combining these two, subsidy and restrictions on the dirty fuels, encourage people to switch and preventing them from reverting back to dirty alternatives. So what they actually do, they implemented this program, kerosene to LPG conversion program. This is how it looks like for the kerosene, which is the types of dirty fuel. And they're replacing it with the LPG, liquid petroleum gas. It's well known as a better, cleaner substitute relative to kerosene. So they're providing this and providing subsidy on the B, and then restrict the quantity of the fuel used for the kerosene stoves. And they started about 2008, and then we can see here they increase amount of supplied of LPG to the household, and then subsequently also at the same time reduce the quantity supplied of the kerosene to the household over time. So this paper really documents a new evidence on the impact on clean cooking on adults' health and labor outcomes using policy experiments in Indonesia, and we attempt to provide plausible mechanisms behind our findings. And I'm going to describe institutional details later, but for now I want to briefly mention about our source of variations to identify the impact, which is the program timing and household eligibility. So usual questions is whether there are some selections on when the districts get the program first and why they get it later. So what we need to assume in order to be able to infer causality, so we need to assume that the timing when the program when the district get the programs is unrelated to the factors that influence health and labor. And we argue that this is plausible because, first of all, this is an energy program. So it's unrelated to factors. It's not targeted to any kinds of characteristics that might influence health and labor. And the second one is that during the expansion period in which the period that we are focusing on in this analysis is that when they want to expand the program, because the state-owned oil company, who is the program implementer, has direct instructions from the government to expand this program as quickly as possible. I will explain why behind the targeted deadline and strict time constraint later on, but essentially these give rise to more sort of some districts are getting because some time constraints, some distributional constraint that is unrelated to health and labor. We also take advantage of panel data of individuals, so we'll be able to absorb some of the time invariant characteristics of individuals. We also show that really health and labors of these individuals are seems to be trending similarly, and the fact that some households are individuals living in the same regions but they are not eligible to the programs, we don't see anything happening for them. So it's gives some reassurance that what we capture is really the causal effects of the programs. So this is just to give a reasons why we focus on the expansion period. Expansion period started from 2019. So before they already started, but since there's some learning going on, they tend to select regions in the beginning of the phase. And this is what we see when we plot the wealth index of the regions. This is documented in another earlier paper suggesting that some selections may occur during early phase of the programs. However, after the early phase, which is the expansion phase, it seems that the districts are looking more and more similar. So this is reassuring in terms of the comparisons that we use in our analysis. So to preview the results, in case I didn't get everything much more in details, but here what we find is two things. First, for health impacts, and then the labor. So for health, what we see is that we see improvements on women's health, but only women, not for men. I think this is consistent with the fact that women are the one who's responsible for the cooking in the household. Therefore, if there's any changes in that types of cooking, it's getting better, they are the one who is more affected on that. So this is consistent with that. And we also see that those who spend more time at home, we proxied it by if their baseline primary activities is housekeepers, they tend to enjoy greater health benefits from it. So this is consistent, being the fact that women responsible for cooking and they spend more time at home. It's consistent with the stories of indoor air pollutions. So if you indoor air pollutions and exposures. So a lot of studies on exposures of using dirty fuel talks about the more you are exposed to the dirty fuel, you're the one who is cooking, spend more time at home, are the one who more likely to negatively affected by the pollutions. And the fact that we improve and replace it with the cleaner alternatives, those are the ones who get the most benefits out of it. And since we find some evidence on health impact, and therefore it motivates us to look at whether there are subsequent effects on the labor. And then what we see is that women's increase their work hours, and primarily among those who enjoy the health benefits. So it means that those who likely to enjoy the health benefits are those who increase their work hours. And we think that the main channel is that the fact that they're healthier allow them to do so. And also it's possible that children are healthier. Although we don't look at specific health measures for children because it's not available on the data. However, we see that those living in the household where there are more children get the the labor impacts on that household with more children are bigger. So we think that it's not inconsistent with the fact that children's probably are healthier, or sick less often. So freeing up some time of women from taking care of their sick children. And the interesting part is also men. So we also see an increase in work hours among men, primarily in the household where women, primarily in the household where there is at least one woman who enjoy the health benefits. So I'm going to talk to more details about this, but essentially what we see is that households who get the benefit, health benefit of the programs, the labor impact of both men and women's improve. And we thought, I'll talk more about possible channel, which is substitutions and complementarity. So if I can summarize one sentence of key takeaway is that clean energy appears to be able to reduce health disparity, and then it all can also improve labor outcomes for not only women, but also men. So we contribute to broadly for a big literatures on energy, labor, and gender nexus. Most of the papers, argues about the time channel, the fact that, as I mentioned earlier in the very beginning, it can free up some of the time doing household chores more efficiently. We contribute to possibly new channels, providing new evidence on this health channel. And the second one is a causal impact on clean energy adoptions. So most of the studies focusing on providing improved stoves and all that. So here we focus on providing fuel, and we argue that if we providing the newer, cleaner fuel, it can be more sustained because it's not subjected to the stoves being broken and all that. So if we providing the energy, that source of energy that is cleaner, could be more sustained, and therefore we be able to see some impact on that. And the third, we also contribute by focusing on adults. Most of the literatures in this field has been focusing on children. It's true that they are the most vulnerable to this type of environmental risk, but adults is important to look at if we want to look at the labor outcomes. And then lastly, contributed to missing adult women in the developing countries. Mostly existing studies argue this missing adult is coming from the disparity at birth. So for instance, sex selective abortions and all. So we contribute to the possibility that environmental risk can also explain some of these missing adults women. So I'm going to explain the programs a bit more in details, our data and empirical strategy and main results on health. And then we explain the possible mechanisms, and then explaining results on labor, and then explain the possible mechanisms, and then conclude. So the program. So it's a nationwide program in Indonesia. It started 2007, and it attempt to convert about 50 million of household to use LPG. So within only 5 years, because at that time, there's a rising cost in subsidizing kerosene. Kerosene has been always subsidized. And because the oil price increased in 2006, the budget of subsidizing is exploding. So the government decide, let's stop, let's reduce the cost of subsidizing kerosene and replace it with LPG. At that time, subsidizing LPG is more, the cost is less relative to subsidizing kerosene. Therefore, they start this program. So those who are eligible are those who never used LPG before, and the steps are, they're going to get the free starter kit. So they will get the stoves, a hose, and a cylinder, so that they'll be able to start using it immediately. And they will also get the subsidy on the refill of the LPG. And after they distribute these starter kits, providing the subsidy on the LPG refill, then they restrict the kerosene quantity though. So they reduce the supply on the quota on the subsidized LPG on that particular districts. So how the kerosene versus LPG compares in terms of the pollutions they produce. So for instance, one paper here compare kerosene and LPG, and it's starking difference in the average of PM 2.5. Yeah, in short, I also summarize it. In short, LPG, there's no doubt LPG is a lot cleaner than kerosene. Although it's not zero, but it's relatively a lot more cleaner. So in terms of health, I think it's pretty clear. We replace it with lots of better, cleaner technology. However, the labor supply is a bit unclear. This is what I mean. So suppose women and children are sick less often, so they have some more free time because now they are healthier, so they can increase their work hours and participate in market work. However, it could also possible that we don't see any increase in labor supply, maybe because the health impact is not that large enough to influence labor's their choice of labor. It could also that their healthy time, they prefer to spend it on leisure, so it's not directly translated to labor supply. Also could be because they have no options to work due to limited opportunities outside to participate in market work. So this is possible. So really our contributions here in this paper is to look at empirically whether we can see any increase, any changes in labor supply. So the data that we use is administrative data on the program implementations from the state-owned government oil company, which is the implementer. So they record which districts get the first LPG starter kit. Of course, within 1 year, we cannot finish it. So when they started, so which district, when the program started on specific districts. So it's a yearly data for LPG rollout at district level. And we're going to focus for our treatment is the early exposed districts. So districts who get the programs in 2009 and 2010, who first get the LPG in 2009, 2010. So, and later exposed districts, this is our control group. So what we are comparing is really the timing difference. So we are not comparing those who get it versus not get it, but we really just use the variations on which one get in earlier and later. I mean, to some extent, we can conclude that this is sort of early treatment. What is the impacts on getting the programs earlier? So it could be served as a lower bound if the fact that we are comparing with the districts that receive none of it. So that's what we are estimating. So 0 or 1 treatment dummies. We also refine it into several dummies because we can also split it in terms of years of exposure. Some districts are exposed to 0 to 2, 3 and 4, and 5 and 6. But main specifications, to make it simpler, we use 1 and 2 because, yeah. So for the outcomes data, we use Indonesian Family Life Survey. This is a longitudinal data often used since it has a great advantage in terms of low rate of attritions. And we observe it 3 years of survey, 2000, 2007, 2014. And the program started in 2009. So we have 2 surveys covers pre-program, and then 1 after the program. So 2007 is our baseline year, and we be able to identify those who never use LPG at the baseline. So we categorize it as eligible household, and in which our most analysis is focused on. We also know some household that is ineligible, and we can certainly do some placebo checks on them. So we use different event study style in which these are outcomes, and our treatment is here, which is the dummy of early exposure if they got the programs in 2009 or 2010 versus if they got it after. So interacted with post, and here post is just a dummy if it is 2014. And we have another term here, which is interacted with pre. So this is a dummy if it is 2000. So essentially beta 1 will capture the intent to treat effect due to the longer exposure to the program. And beta 2 will captures the pre-trend before. So the difference between 2000 and 2007. So the fact that we don't see statistically different in beta 2 suggests that the outcomes for those who are early exposed versus later exposed are not trending differently. And we use some specifications, districts fixed effects, and also in most comprehensive one, we use individuals fixed effects. So our outcome variables is lung capacity to proxy for health. There's some benefits. I will explain it why use lung capacity. And for labor, we will use work hours, numbers of work hours dedicated to market work, those who are income generating hours. So this is not work hours spending on household chores. Okay, and I will show beta 2 later. So lung capacity, there's some advantage of using these as a proxy of health. It's really based on medical literature, it's a strong predictor of mortality for elderly, and it's a reliable measures because it's also not easily influenced by contemporaneous factors, weathers, like if you use cough, for instance, it may be easier to be influenced by many other factors, but lung is relatively stable over time. And you use some device like here, you blow as strong as possible within 1 minute, and it will measure the volumes of your lungs. So we think this is a good proxy for health. Some smart statistics I want to point out here is that we know the cooking fuel use. Here is a baseline, which is 2007. So the characteristics at the baseline, there are about 90% using kerosene and firewood. Of course, this is just 0 or 1, whether they reported they use kerosene or they use firewood. Of course, they can, in fact, mix these two, which in reality, they use a mix of fuels. Therefore, we don't, but in general, those who are eligible are 90% of our observations, and 10% are those who are ineligible. In terms of how the programs work, as I said, they distribute the LPG. They also gradually reduce the quota of the subsidized kerosene. And what we see here is that those who are early exposed, they are no longer purchasing kerosene in 2014. So after the program, they stopped buying it because it's being restricted unless you want to buy it in an expensive price. But you have the other alternatives. Now you can use LPG. Now people are using LPG and stop using kerosene. For the later exposed, we can still see that there are some, it seems not changed. They seems to still consume kerosene because these programs take time. So it's not just 1 year distributing this LPG, it's gradual. So also the restrictions on kerosene is gradual. So what we see is here is that there's still not much of a changes on the kerosene purchase for those who are later exposed. And for the beta 2, as I mentioned briefly, is the interactions of the treatment dummy and the pre. So which is the dummy if it's year 2000. So this is capturing the pre-trends, and we don't really see much of the differences in trends in the lung capacity, women's and men, hours per work per month. We also don't see in some other self-reported health measures, anemia, diabetes, self-reported health, weight and cough. Also some other characteristics, educations, income, electricity, and others observed household characteristics. So reassuring that these individuals living in these regions seems to be trending very similarly. So in terms of the programs on the take-ups, so here, if we compare just a simple histograms of what happened before, which is 2007, and what happened after. So LPGs dramatically increased. Before it's only 10%, now it's about 70%. And the kerosene is decreased in 2014, and also some firewood. So we can see that the programs really works in increasing the take-ups rate of using LPG as the primary cooking fuel. And if we split it in terms of the years of exposure, so the more you're exposed, the more likely you're using LPG, and the less likely you're using kerosene. And for the likelihood for you to use firewood, it seems not so much of a impact on that, which is what we expected, because the program is really works through providing LPG and reducing kerosene. So some suggestive evidence, if we just plot raw average of lung capacity, if we see if the households is always using kerosene in the 3 rounds of survey, so kerosene, it means that they never switch. They keep using kerosene. What we see is the average lung capacity is essentially just flat, I would say. In contrast to those who switch at some point in 2014, no matter what they use, kerosene or fiber kerosene, it's 2014 they increase. They switch to LPG, and what we see is the average lung capacity increase. This is just a rough average. So this is motivates us to do some further analysis on this. Maybe the question is whether there's any gender disparity to begin with, and the answer is yes. So here we see the gray one is the lung capacity for male, and the red one is the lung capacity for female. And the dashed line is if we control for the age and height, we still see some gaps. So it means that there are some gaps that is not explained by age and height. And our contributions here is to say something about this gap, whether this gap can be explained, some part of this gap can be explained by the lack of access to clean energy. And indeed, what we find is about 4% can be explained by the lack of clean energy, which is here. So the program's impacts on health. This is our treatment dummies interacted with post. Here for women, we see a positive increase. It's true, it's very stable. And men, we don't see, although it's positive, but it's not statistically significant. So we find about 11 liter per minute. So it's about 4% of lung capacity increase. So it's equivalent if regular smokers quit smoking for 10 years. So those who are smokers who stop smoking, their lung capacity will improve over 10 years period. And this is about the same magnitude. So it's a sizable, I would say. And we turn to the activities. So we can plot their baseline activities. So, and what we see is here is that women, the white bar, if their primary activity is housekeeping, so mostly are women. So we can now create the dummy based on their baseline activities and do essentially like triple difference. Here we interacted the treatment and then the post and then housekeepers. So essentially this is capturing the increase in the lung capacity from those who do housekeepers at baseline versus those who don't do housekeeping at baseline. So essentially it's captured by those who the impacts on lung capacity among women is experienced by those who are most likely to spend their time indoors, which we proxied it by housekeeper activities at baseline. So that's the results on health. Women's 4%, no statistical, although positive effects on men. And what we think is that improved indoor air quality seems to be primary possible explanations. Why? Because this is an impact on lung. Lung is very related to, based on medical literature, very related to lung, any respiratory problems. Also, it's concentrated on housekeepers who most likely to spend most of their time at home, and is also driven by the those who are exposed longer. So if we look at those who are get the program earlier, they get more improvement, higher positive improvement in lung capacity. We also look at other, for instance, if there are any changes in expenditures, we find it's small, and it's hard to argue that the small changes in expenditures can lead to that size of improvement in health. We also see some other characteristics, and we don't really see much of the changes. Earnings, this should be not, we don't really see statistical changes in earnings, although the coefficient is positive. Local economic changes grow, we don't see any impacts on the ineligible household, which essentially the same, which essentially household that reside in the same regions, the same with those who eligible, but we don't see anything on them. So we don't see that this are driven by any local economic growth. Okay, so our labor outcomes, many other factors can influence labor. So we should focus, what we do here is that we focus on individuals who likely to enjoy the benefits of the program. So we already use these dummies of housekeepers at the baseline for women. Now we define the new one, which is household where there was at least one woman who did housekeeping at baseline. So this is to focus on the men. So we are comparing men who resides in the household where there is at least one housekeepers versus those without any. So what we compare, two panel. This is the first panel, which is those capturing individuals that are most likely to be benefited from the program. So here, women, which is essentially housekeepers women, we see an increase in monthly working hours. So if you see 30, so it's about 1 hour per month increase. And here in the column 4, we use individual fixed effects, although it's not statistically significant, but it's still in the magnitude, similar magnitude. While men, we see some increase, about 1 hour or so per month. And the other panel, which is non-housekeepers or men that does not belong to housekeepers' household, we don't see anything, even negative. So it seems like the programs is not happening here in the household that are less likely to be benefited from the program. If we look at the numbers of children, we split based on baseline numbers of children at the household in the baseline surveys. We do see an increase in working hours for both men and women are concentrated in a household where there are more than 2 children. So this is sort of could be that children are healthier, freeing up some time of them taking care of sick children. It's not inconsistent with that hypothesis. So what did women do? What we see is that they increased their participations in the increase in work hours are those women who participate in agricultures before. So, I mean, in agriculture, you can, even though there's no, it's, so in agriculture it's more labor intensive, so it's easier to increase more effort, more work hours on agricultures compared to other sectors. And I think this is what we see. So to summarize the program's impacts on labor, we see an increase in work hours on women who are housekeepers at baseline. And we think that the primary channels will be the health improvement, because it's concentrated among households who likely to get positive health shocks, and it's concentrated on households with more children. There's also possibility of time saving, maybe with the cleaner stoves, you cook faster, but also there's some literature suggesting there's some possibility of a rebound effects. If it's cooking are more convenient, then you tend to cook more often, longer. So there's possibility that the time saving could be offset by some rebounds. Could be also because some local job opportunity expanding in that regions, but the fact that we don't see any changes in labor outcomes for ineligible households that are residing in the same districts seems to rule out this possibility. So we still think that health improvements may be the main big explanations of this increase. Increase in work hours among men. This is my last piece of evidence. Why the fact that men do not improve their health because of these programs, why they still increase their work hours. So we think of two possibilities: substitution. Women, now they're healthier, they can take up some of the men's effort, for instance, housekeeping efforts. Here we see that men in housekeepers household are less likely, now they are less likely to do household chores, but they now more likely to get the secondary job. So they have some primary job, now we create some indicator if they have secondary job, and we see the likelihood increase. So they could shift from doing housekeeping chores before, and now they get secondary job. I think this is what we see. There's also possible complementarity, because now it's easier for women to pick up some slack, acts as a complement for men in where they were in the same sector to begin with. So we split the samples. If they're both in the same sectors, it's easier for women to act as a complement. So that's our argument. So if they're both in agriculture, what we see is that the area is cultivated is increased, and to some extent, numbers of crop variety increase. So it could be some indicative evidence that there are more activities are done when they are both in agriculture. It could be also, it could be well that now women are act as a complement on this. Some robustness. I think I'm on time now to conclude in 45 minutes. So what we see here in terms of the program seems to work, and the characteristics of the program is that it combines price subsidy on the clean energy, the cleaner one, the cleaner alternatives, and provide and restrict the quantity for the dirty one. It leads to the high adoptions, and these high adoptions improves women's health and also women's labor outcomes. Although men seems to accrue some small health benefits relative to men, they increase their working hours. And so it seems to me, seem to point some evidence that clean energy can benefit not only women, but also men. Of course, ignoring these spillovers usually it's very hard to quantify in the policy discussions. Therefore, we underestimate this benefit of clean energy. Yeah, I think it hopefully provides some lessons for policies on promoting clean energy in the developing world.
Thank you, Imelda. We can then open the floor to questions and comments, and we've enabled the camera, so please turn on your camera too if you ask a question, so we see who's talking. All right, thanks. Well, if no one else is asking a question for now, I'll start. How would you say how important are the results economically? If the effect on lung capacity was it 4% and about 1 hour per week more work? What would you say? What's your sort of overall policy message here? Is this an important program?
Yeah, it's I mean, additional work hours, one per, we could multiply it by wage, which we didn't do yet. But yeah, the economic benefits, it could be 1 additional hours per day multiplied by the wage rate, which is probably about $1, let's say, at the minimum.
Okay, yeah, I got that one wrong. I thought it was 1 hour per week, but it was 1 hour per day. Okay,
yeah,
that's quite a bit. Okay, then Frederick, please go ahead.
Yes, thank you, Imelda, for presentation. Did you see some generation effect? Is there an effect of the age of the women and of the men which should influence their behavior?
Age effect. Well, we control for age, but we don't specifically be able to say something about the fact based on age. I mean, I suppose that certain range of age are those who are more productive. So it could be that some range, the effects could be larger than others.
No, it was just a question for me, for my understanding, if there were some change between the beginning of the program and the end of the program, which makes that perhaps if there is a difference of structure of age between women and men, we could have some differences of behavior or not.
But we are tracking the same individuals, no?
Okay.
So that
okay. So the same who are oldest after. Okay.
So we are comparing the same age. So individuals age 40 versus another individuals living in the regions that treated later at the same age as well.
Okay, yeah.
Mm.
And I have a sub question. For the LPG distribution, the program require a specific distribution system for returnable tanks for the LPG, and the kerosene, you just have your liquid that you can sell quite easily. Yes.
So both are I think it's well.
For LPG, it's a tank that you return when it's empty. Okay. Also, that means that the implementation of this plan implies that there was a new distribution system to could deliver these small tanks of LPG.
That's true. So maybe you want to point out that probably there are some sort of labor impacts outside of household. Is that?
Yes, or perhaps for some people it should be too complicated, or they don't want to change as their way they cook at home.
Yeah, certainly people. So in most of the cases, why it's so hard to make people switch, it's because their preference. Some people don't like to change. Maybe there's more work with the new type of fuel. They're not used to it. They don't want to change. Yes, that's the reality. However, in the context of these, they design it in such a way there's not much of options for household to stay using the dirty one, the kerosene, because they limited the quota for the subsidized quantity. So unless you want to pay a higher price, then you better use the new one. Even though it's a little bit less convenient for you, but this is the tricks, they did it in such a way that it promotes the adoptions on that.
Thank you.
Good. Then we have a question from Akli Berry, please.
Yes, thank you. Do you?
Yes, Akli's arrived.
Did we, Akli, are you?
Yes. Yeah. Do you hear me now?
Yeah, can hear you.
Okay, thank you. I'm sorry for the muting that I did not remark. I have a question about one point is about the effect on labor outcomes. You said that it was apparent from one of the slides that women participation increased in agriculture and also in manufacturing. I understand that it's in terms of hours worked, or is this?
So this is hours of works splitting based on the sector. So here it means that the increase, working hours increase for those women in agriculture sectors at baseline. And
that means that the switching to the modern means of cooking allowed some times to be saved and then spent.
Most occurred in those who were in agriculture.
Okay, I do not really see the reasons for a higher rate for agriculture than for manufacturing, but what is striking is the fact that for social service, the impact is negative. That is a decrease.
Yeah, but essentially 0. Yeah.
Sorry?
So yeah, I mean, yeah.
It's 15% or something like
So
that?
this is, it means on
Is
average.
it a percentage or not?
So no, this is working hours. So it means
Okay.
15 hours less per month. So about half an hour.
Do
Yeah,
you know
although
why is
our
this?
observations is small. Our
Do
observation
you
is
see
very
why
small.
is this for the social service
I
in
mean,
particular?
we could translate it as 0. So there's nothing changes in working hours for them. This is just, yeah, because of the,
so this is the absolute, this should be the absolute number of hours worked in the social service?
monthly work hours. So numbers of hours.
So it should be 0.
Before they probably work more, and then now in 2014 they work less in terms of numbers of hours for those who are in social service at the baseline. Yeah, but I mean, yeah, this is to indicate we need to note that majority are in agricultures, and therefore our observations are really suffer here for other sector. But it's to indicate who are these women who increase their work hours, and what we indicates is that those who are in agriculture. I mean, seems to be obvious as well, because majority those are working in agriculture.
Well, but what is puzzling is that one would expect with the saving of time that the offer of labor or the time spent working could have some margin of increase, whatever the sector. But the social service sector is seems special, but I don't know why.
Yeah, but we need to, yeah. I mean, social service could be, yeah, it requires some slot, so some demand from the supply side, right? So it could be influenced by that, the demand for the worker, for social service worker.
Is cooking for someone else considered as a social service?
No.
Okay.
No. No. I think this is social service for, I don't know specifics, but could be some types of jobs, some other types of sector.
Okay. The other point I remarked is about local job opportunities, and so you concluded and showed that that there was no effect on non-eligible households. So why did you put this forward? Is it because you expected some effect on the global labor market in the district, for example?
Yeah, could be because of the having this new facility of refilling. So it could be some demand for local jobs. It could be well the case. But if this is driven by that, it means that those who are living in that same exact regions should also increase working hours, yeah, some labor. And the fact that we don't see any changes for those ineligible seems to be not indicating that local job opportunities drive these labor outcomes. So it seems not driven by anything from the supply side.
So yeah,
for demand side.
The job opportunities would be, for example, in distributing these new software or appliances of cooking, or even repairing or something like that.
Yeah, something like this.
Okay, thank you.
Okay, thank you. Is there any one final quick question? If not, I'd like to remind you that, well, first I'd like to thank IMELDA, and please stay online for a moment longer. And for everybody else, the next seminar is on November 23rd, and Olivier Dechenes is giving a talk then. Thank you.
Thanks, everybody.
Thank you very much. Thank you.